Welcome to this episode, where we're diving deep into the first stage of labor, focusing on nursing care and assessment during this critical phase. It's a complex time, not just physiologically, but psychologically, for the patient and their family. Today, we'll unpack the phases of labor, admission criteria, the nurse's role, assessment techniques, infection prevention, and best practices for supporting laboring patients. Ready to get into it?
Absolutely. It's such a pivotal stage, and there's so much nuance in how care is delivered. The first stage of labor really sets the tone for the entire birth experience, doesn't it?
It does. Let's start with the basics of the first stage itself. It begins with the onset of regular uterine contractions that cause cervical change and ends with complete cervical effacement and dilation. Effacement meaning the cervix shortens and thins, and dilation is the widening of the cervical opening.
Right, and the Society of Obstetricians and Gynecologists of Canada divides this stage into two phases, the latent phase and the active phase. For nulliparous patients, the latent phase is from 0 to 3 centimeters dilation, with the cervix less than 1 centimeter long. For perose patients, it's a bit wider, 0 to 4 centimeters dilation.
And the active phase starts at 4 centimeters for nulliparous patients and 4 to 5 centimeters for perose patients. The duration varies quite a bit. Latent phase usually lasts about 6 to 8 hours and active phase about 3 to 6 hours. But that depends on parity, fetal position, patient emotions, and activity level.
Exactly. And the contractions themselves change character. In the latent phase, they're mild to moderate, irregular, spaced 5 to 30 minutes apart, lasting about 30 to 45 seconds. Then, in active labor, they become more regular, stronger, moderate to very strong, 2 to 5 minutes apart, lasting 40 to 90 seconds.
The behavioral changes are interesting too. In latent labor, patients might be talkative or calm, but as they move into active labor, they often become more serious, fatigued, and may express fear or frustration. It's a shift from external focus to a more inward, intense experience.
That's a good point, and it ties into how nurses need to adapt their approach as labor progresses. But before we get there, let's talk about admission criteria. Nulliparous patients often come in during the latent phase because they're unsure when the right time is, whereas multiparous patients tend to come in during active labor.
Yeah, and nurses have to assess whether admission is appropriate. Sometimes patients in latent labor are encouraged to stay or return home to allow labor to progress naturally. The guidelines suggest primiparous patients come in when contractions are 4 to 5 minutes apart, lasting about a minute, for roughly an hour. Multiparous patients can come in when contractions are 5 minutes apart, or sooner if coping is difficult.
Educating patients on distinguishing true labor from pre-labor is crucial here. True labor contractions are regular, stronger, longer, and don't stop with activity or position changes. Plus, cervical changes like softening, effacement, dilation, and the presence of bloody show are signs of true labor.
The bloody show is often overlooked, but it's a key clinical sign. It's sticky, mucoid discharge that increases as the cervix effaces and dilates. It's different from vaginal bleeding, which is more concerning.
And in many Canadian units, the obstetrical triage acuity scale is used to prioritize assessment and admission based on acuity. Nurses in triage have to balance emergency presentations with patients in early labor who might be better managed at home.
That's a tough balance. You don't want to admit too early and cause unnecessary interventions, but you also don't want to miss complications. It's a fine line.
Speaking of interventions, the nurse's role in shaping the childbirth experience is critical. Negative experiences can lead to PTSD, perinatal mood disorders, bonding difficulties, and even affect future family planning.
Absolutely. Nurses need to be empathic, respectful, supportive, and professional. The document highlights qualities like being kind, patient, calm, comforting, and encouraging. Active involvement of patients in decision-making enhances their sense of control and satisfaction.
Family-centered care really frames labor and birth as normal life events, with the patient and their support people as active participants. Nurses should orient patients and families to the unit, explain procedures clearly, and include support persons as desired.
Comfort measures during latent labor are also important. Warm showers or baths, massages, light meals, and diversional activities like walking or reading can reduce anxiety and discomfort.
That's often underestimated. The environment and small comforts can make a big difference in how patients cope early on.
Moving on to assessment on admission. It starts immediately, whether by phone or in person. Nurses collect detailed history, expected date of birth, obstetrical history, medical conditions, allergies, contraction pattern, membrane status, vaginal discharge, fetal movement, and pain characteristics.
Reviewing antenatal records is key to identify risk factors like gestational hypertension, diabetes, infections, anemia, or previous birth complications. Psychosocial and cultural factors, mental health, intimate partner violence, and substance use should also be assessed.
The physical assessment includes vital signs, general systems review, heart, lungs, skin, checking for edema, reflexes if indicated, and baseline fetal heart rate. Respiratory status is crucial in case general anesthesia is needed emergently, so checking for colds, allergies, and last food intake is standard.
Reviewing the birth plan and preferred pain management and newborn feeding methods is also part of the initial assessment. Documentation has to be meticulous.
Infection prevention is a big part of care. Group B streptococcus screening is essential since 10 to 30% of pregnant patients carry GBS. Risk factors for neonatal infection include positive culture, preterm birth before 37 weeks, prolonged rupture of membranes over 18 hours, intrapartum fever above 38 degrees Celsius, and history of early onset neonatal GBS.
Intravenous antibiotic prophylaxis with penicillin G is standard for GBS-positive patients during labor. Timing is critical. At least one dose 4 hours before birth for adequate prophylaxis. Alternatives exist for penicillin allergies.
Herpes simplex virus screening is also vital due to the risk of neonatal infection. Vaginal birth is preferred if no active lesions or prodromal symptoms are present. Cesarean birth is recommended if active lesions or prodromal symptoms appear at labor onset or membrane rupture.
Antiviral therapy starting at 36 weeks, like acyclovir or valacyclovir, can reduce outbreaks and the need for cesarean births. It's a good example of proactive management.
On to physical examination and monitoring. Initial exam includes general systems assessment and fetal status. Uterine contractions are assessed by palpation or electronic monitoring.
The contraction pattern is like a wave. Increment or buildup, acme or peak, decrement or letting down, and then a rest interval. Frequency is the number of contractions in 10 minutes, averaged over 30 minutes. Intensity is the strength at peak, assessed by palpation or internal monitor. Duration is the length from start to end, and resting tone is the uterine muscle tension between contractions.
Vaginal examination determines cervical dilation, effacement, position, station of presenting part, membrane status, and amniotic fluid characteristics. It should only be done when indicated. On admission, significant labor changes, patient request for pain meds, or abnormal fetal heart rate.
Leopold maneuvers help identify fetal presentation, lie, attitude, and engagement. And fetal heart rate auscultation is done at the point of maximal intensity, usually over the fetal back.
Monitoring uterine activity and fetal heart rate is essential to assess labor progress and fetal well-being. Graphic charts or partograms plot cervical dilation and contraction patterns to identify deviations early.
Safety is paramount. Labor involves exposure to blood and body fluids, so strict routine precautions are mandatory. Hand hygiene at 4 critical moments: gloves, protective eyewear, gowns, masks as appropriate.
Supine hypotension prevention is important too. Patients should be encouraged to lie laterally to maintain uteroplacental perfusion. Blood pressure monitoring should use validated equipment since automated devices can be inaccurate in pregnancy.
Heart rate assessment by auscultation or palpation is preferred over pulse oximetry. These details matter in ensuring accurate monitoring.
Artificial rupture of membranes, or amniotomy, is performed if membranes don't rupture spontaneously. It's done with an amni-hook or clamp. Time, color, amount, and odor of amniotic fluid must be documented.
Normal fluid is pale straw-colored, watery, and without strong odor. Abnormal findings like meconium-stained, yellow-stained, bloody, or foul-smelling fluid indicate possible fetal distress or infection.
Umbilical cord prolapse risk increases after rupture, so fetal heart rate must be monitored closely immediately after.
Signs of potential labor complications include contractions lasting longer than 90 seconds, more than 5 contractions in 10 minutes, resting tone less than 30 seconds, intrauterine pressure over 80 millimeters of mercury, abnormal fetal heart rate patterns, meconium-stained or bloody vaginal fluid, arrest of cervical dilation or fetal descent, maternal fever over 38 degrees, foul-smelling vaginal discharge, and persistent vaginal bleeding.
Those are critical red flags. Nurses must be vigilant and communicate findings promptly.
To wrap up, labor is a dynamic process requiring continuous assessment and individualized care. Nurses play a pivotal role in supporting patients physically and emotionally, influencing birth outcomes and future childbirth experiences.
Evidence-based practices like Dramatize, healthy birth practices, promote spontaneous labor, freedom of movement, continuous support, and non-supine pushing. Patient education on labor signs and when to seek care reduces unnecessary admissions and anxiety.
Meticulous documentation and communication with the healthcare team ensure safety and quality care. Infection prevention protocols and timely interventions for GBS and HSV are critical to neonatal outcomes.
Understanding the nuances of labor progression, contraction patterns, and fetal monitoring allows early identification of complications and better outcomes.
It's a complex biopsychosocial experience, not just a physiological event. The nurse's role in trauma prevention and patient empowerment can't be overstated.
Well said. Thanks for joining us in this deep dive into the first stage of labor. We hope this discussion adds depth to your understanding and practice.
Thanks, everyone. Take care.